You being of the professional level you are, I'm sure there's at least 4 assistants in there with Morris Divas, Langenbecks and
Omnitract.
blood products.
Omnitract.
And
Thank you for coming in.
I've taken that out.
Sorry.
No, absolutely taken it.
Sorry. Today we're going to talk about hernias, inguinal hernias, how to manage them operatively. We're going to talk about the operative steps, and we're also going to discuss when you are recommended to choose one approach more than the other.
Absolutely. Last podcast that we had talked us through some scenarios and we had a bit of a discussion. Today's going to be really on the operative management, as you said, and the guidelines. What's your favorite way of doing a hernia? Or rather, what are the procedures that we need to really know, irrespective of subspecialty?
I'll talk about open inguinal hernias.
Excellent start. Let's do it.
It's a bit of a sore topic for me. It's probably the most difficult operation during my training that I had to learn, because it was the learning curve for me for that operation was strangely higher compared to other things.
Understanding anatomy, right? It's like a 3D thing, and understanding it took a long time.
Yeah, absolutely.
Yeah, I agree.
So we've got our patient. This is the last time I'm going to say so. We've got our patient. They're supine, they're prepped, they're draped, they're consented. We've done a checkout, we've done a timeout, we're ready to go. Patient's properly prepped and draped. I'm going to start a transverse incision overlying the hernia 1 centimeter above the pubic tubercle and extending it laterally towards the ASIS. I'll try and keep the cut alongside the skin creases if I can to gain the best dissection possible. The landmarks here is that the hernia will be lying one finger above the pubic tubercle, and the deep ring will be at the midpoint between the pubic tubercle and the ASIS. So that's where your incision needs to cover. Obviously extend it accordingly based on if you're not happy doing an operation, you can extend it as you can, keep it safe as you can.
Excellent. That's positioning covered. Incision where you're going to do it and describe it in those very nice clear terms. 1 centimeter above, 2 centimeters, 1 to 2 centimeters above the inguinal ligament. And just be clear in your mind that you have a phraseology that's very easy and natural, as Mo just demonstrated. Incision's done. You've opened up the skin. You've got a subcutaneous tissue. Talk us through the rest.
We've got the skin. We're going towards the external oblique aponeurosis. You need to talk about the layers. On the way there, you'll come across the superficial scarpus fascia that you divide. Some people divide it bluntly. Some people divide sharply with diathermy or scissors. Again, do what you're comfortable doing. Do what you're doing day in, day out, so that you are more succinctly capable of describing what you're doing. We'll come to the sheath. I like to lift the skin, all the tissues above the sheath, so I can see the reflection into the inguinal ligament. So I'm comfortable that this is all that I can see. You can also continue your dissection medially. So if there's a sac dangling outside and going into the groin or going into the scrotum, you can also see that as you go down.
That's actually very good point, not just for the exams, but also clinically as well. It's a good idea to be able to see the lower edge, i.e. the inguinal ligament, because the danger is that as soon as you get to the external oblique and you start using a knife or diather or whatever to open it, you can be way too high or way too low, and then it becomes a bit difficult to...
Starting a kidney transplant or inguinal hernia.
and then everybody's going to suffer in that theatre in various ways. So it's actually a good idea to identify the inguinal ligament before you open the external oblique. Okay, you've separated, you've got your Travers in there, your tractor in there, you've got assistant, whoever you have. You being of the professional level you are, I'm sure there's at least 4 assistants in there with Morris Divas, Langenbecks and
Omnitract.
Blood products.
Omnitract.
And so you've got your dissection down to the external oblique.
Please Omnitract, please subscribe, please support coming in. It's my favorite retractor.
There's going to be a limit as to what we can ask for.
Yeah.
An I&D, can you get Omnitract?
Yeah.
If you can, where you work, tell us where you work and we'll come and
we'll try and work for you.
You're down to external oblique. External oblique is there.
External oblique is open.
It's not open yet, so you're down to the external oblique. How do you open it?
You want to be a bit clear about how you're going to open it. The nerve injury can happen at this step. So you want to undermine from the external opening towards the internal opening, lift the external oblique above the contents below, and also lift the nerves away. So you can insinuate your tip of your scissors through the external ring under the external oblique. Once you've pushed everything out of the way, you can then cut along that line that you've made. Again, cut with your favorite instrument of choice. Get the edges of the external oblique on either side in clips, lift, push the things that dissect the things that are attached to them away, dissect the nerves away, dissect the spermatic cord that's attached away. Once you've created that space, that pocket, you've opened the inguinal canal essentially. Now you move on to isolating and mobilizing the spermatic cord.
Absolutely excellent, and that's a good point to just recap what was said there. So what Mo's just said is that essentially you have opened the external oblique and made your pocket for your mesh. That's what you're doing by any means that you want. Protecting the nerves, important. Sometimes you have to sacrifice it, and there's various discussions as to whether you should use sharp dissection to excise it or not.
Again, use what you're comfortable using. You will use what you use day in, day out.
Pockets made, you've got a north or south kind of lip of the external oblique. What do you do?
So you have your leaves of the external oblique open, divided, and out of the way. Next step is you're mobilizing your spermatic cord. You're lifting it off the back wall. You're lifting it off the internal oblique muscle. You may have to do this sharply. You may have to do this with diathermy to ensure hemostasis. And you want to lift the cord all the way. It's freed all the way. So it's the only attachment from the back to the back wall. It's his exit through the deep ring. And you then isolate it and loop it with nylon tape or a ring holder or whatever you have. And moving on to dissecting the cord. We're not going to spend a lot of time on this. Use, again, your favorite instrument, favorite approach, whatever you're comfortable with. So we'll say this a lot.
Just take care.
Protect the vas, protect the vessels, protect the veins. I personally don't cut out any lipomas. I think they contain the veins, and that preserves the blood supply. There's no really indication to do that. Again, I refer to the original Liechtenstein paper or the modified Liechtenstein paper. Anything coming out of the Liechtenstein Institute, you'll rarely find anyone who can doubt you if you're citing the Liechtenstein documents that are coming out in terms of describing Liechtenstein technique. And then next step is finding the sac. The sac is the most superficial, the most lateral object if it's an internal hernia coming into the cord.
It doesn't mean internal.
Sorry, indirect. That's what I mean. Indirect structure going into the cord. That's
next week's show. We're just going to have a little puppet. He's going to move his mouth. We're going to have different words coming out.
Yeah. That's if it's an indirect hernia. If it's a direct hernia coming through the back wall, again, you can say you're going to plicate it. Again, stress that I'm sure that you've done hundreds of times in theatre is that it doesn't actually affect the repair, but it allows you to place the mesh flat. Once you've identified the indirect sac, you're separating it away from the structures, taking care to preserve the vas and the vessels. You're plicating, reducing, cutting, ligating, whatever you want to do. You can do that. Open it or not open it. Again, whatever you do. This is part of my practice. I do this or I don't do this. Be prepared to provide reasons. Have the sac identified. You want to take it away from the other cord structures without injuring them. So you want to preserve the vas. You want to preserve those vessels, the pampiniform veins. Dissecting the sac might sometimes mean that you have to cut through the cremasteric muscle. That bleeds. Make sure you use diathermy or any other form of hemostasis. You want to dissect, and the more chronic the sac is, the more attached it's going to be. These are all kind of really extensive details, but it might be worth dropping one or two of these details to show that you have experience and you're comfortable and happy doing this procedure. Agree?
Agreed. You've reduced the hernia.
You've reduced the hernia. You've dealt with the sac however you choose to deal with it. The next step is to ensure this hernia doesn't come back.
How do you do that?
You want to attach your mesh in a tension-free style, and you want to reform your deep inguinal ring and also protect against a medial recurrence. These are the three key steps, I would say, for an open inguinal hernia repair.
Excellent, because medial recurrence is the most common one. Ultimately, the mesh you use or don't use, up to you, whatever you want to use. Something non-absorbable. The guidelines recommend that you use something with lots of holes in it and it's lightweight.
Lightweight, lots of holes. There's no difference in how big the holes are. The lightweight is the same. It might be better, I think, in terms of the pain compared to a heavyweight. And then how you attach the mesh doesn't really matter.
Non-absorbable suture for most people, medially, and then you run it across.
Personal note, I'd like to see more fine ethibond being used. It's very nice in terms of handling, and it's the whole world different to the proline that they give us to torture us with.
You're going to ask them to sponsor us as well.
Ethibond, please sponsor us as well. J&J, please sponsor us.
So we've got the mesh now secured by, traditionally most people tack it medially with a suture.
You want it
across
so
the ligament.
The pitfalls that you need to kind of mention is that the mesh needs to go beyond the pubic-tubercle medially to prevent against the medial recurrence. It needs to be attached and identify all the nerves out of where you're putting the sutures in, putting continuous sutures along the line.
Not rolling up, flat enough, but not too tight.
Exactly.
It's going to shrink.
You need to not reconstruct your deep ring, not too tight on the spermatic cord. The traditional teaching is that needs to accommodate the tip of your little finger, no more than that. Otherwise, you can expect another recurrence coming in through for that.
Excellent. Mesh is in place. You've secured it. It's dry. Hemostasis next.
Close in layers. It might be a good tip to say that you can introduce local anesthetic to the nerves when you can see them before you close the external oblique aponeurosis to actually show your understanding of pain relief and things like that. Helps with day case recovery, helps with patients going home, all that jazz. You've closed everything up in layers, maintain hemostasis. You tell the patient to avoid heavy lifting for a couple of weeks. You give them paracetamol, ibuprofen, or whatever analgesia, simple analgesia they can tolerate, or whatever, or however their analgesic requirements are. Depends on your practice. We don't arrange follow-up where we work. Some people give them, they can call a nurse if they've had it somewhere else. And you give them some safety precautions. No driving until they're comfortable making an emergency stop. No heavy lifting for 2 weeks at least. Continue there and then reintroduce their activities normally as they would do.
Excellent. No, that's it. Incidentally, these things that you may think that, why are they going off the tangent talking about the post-operative care and what the patient should and shouldn't do? It's very common in FRCS scenarios to ask this. So it's not just about the technical procedure that you do. It's about what happens afterwards. Remember, you are a first aid consultant, so they're looking for the whole package. They're not looking for somebody who just knows the technical steps very well. Very quickly, let's recap the technical steps. In an adequately consented, prepped, and anesthetized patient, whether that's a regional block, spinal, general, we're not going to go too much into that. You're going to make an incision 1 to 2 centimeters above the inguinal ligament. Immediately below you is the campus, the scalpus fascia, and the subcutaneous fat. You're down to external oblique. You then identify the rolled edge of the external oblique to make the inguinal ligament before you open it.
Yes.
You open it in whichever manner you want to. The external oblique is then opened along the entire canal, so you can see across whether it's direct or indirect and past the deep ring. And then you have the hernia with the spermatic cord in the male, of course, and in the woman it's going to be a round ligament. You've got the structures. You're going to separate them, as Mo very nicely described, with diathermy, sharp dissection, blunt dissection, combination of things. Reduce the hernia back into the abdomen, ligate the sac, don't ligate the sac, up to you. Placate the back wall, don't placate the back wall, up to you. Then you're going to reinforce, you're going to reconstruct.
Reconstruct your reinforce your hernia repair and reconstruct your mesh.
We know, of course, that the suture repairs in North American clinics have been superb in most people's hands.
In their hands.
Yeah, in most people's hands in the world, it's going to be a mesh. Okay, so in an exam, it's always a mesh. You're going to put a mesh in, and how you tack it, how you suture is up to you. There's variation in practice. There's meshes nowadays that don't even need anything to secure them, and that was a cue for you to ask ProGrip to sponsor us. Missed it, doesn't matter.
He loves the ProGrip. I'll leave that to him.
And we'll then you're going to inject local anesthetic if you haven't done so already. You're going to close the external oblique. Usually most people use Vicryl, whatever you want to use. Approximate the fat to reduce the dead space. Close the skin. Pressure bandages if you want to. Glue, plasters, whatever you want to use. Then you're going to give the appropriate post-operative advice, which is until you can perform an emergency stop, don't drive, which is 10 to 12 days. Can have a shower pretty soon afterwards, 1 or 2 days afterwards, but don't have a bath until the skin's healed, which is 5 or 7 days. Don't lift anything heavier than 5 kilos or do strenuous exercise for about 4 to 6 weeks. Nobody's really sure exactly what the best time frame is, but doing stairs, hills, walking around is encouraged. It's a good thing. And that is it. Most people do not follow their patients up. It's up to you if you do. Just say what your practice is.
Should we go to your favourite topic?
My favourite topic is what?
Laparoscopic inguinal.
Laparoscopic inguinal hernias. Yes. Laparoscopic inguinal hernias.
When would you use a TAPP? When you use a TEPP?
When we use a TAPP, the only right answer to that is essentially whatever you are comfortable with. And if that's neither, if you're some of our trainee colleagues in certain subspecialties would not have done a TEPP or TAPP, which is absolutely fine. And if in the scenario you're asked what would you do, you're going to do what you're comfortable with, which is an open repair. But if they say, the patient is in your clinic, they really want a really sophisticated TEPP or TAPP or whatever they want, then the answer is, well, in my hands, I'm only comfortable doing open. I will refer them to somebody else. And they'll usually move on and ask you something else. Do not do something that you do not know how to do or have never done before. It's a bad idea and you get very quickly caught out. TEPP or TAPP, there's no real difference between them. Now that I said that, there's going to be a whole bunch of angry kind of comments from various people across the globe. Mr. Morali, Professor Morali has already got his own opinions on that. Ultimately, though, objectively speaking, there's no definitive real difference between them. There isn't. Okay, some people prefer this and say, well, in my experience, that's great, that's fine, but they're pretty much equivocal. I've kind of been trained to do both, to be honest, and it depends what consultant I've kind of been scrubbed in with. What training I've done, I've probably done slightly more TEPPs than TAPPs, but it doesn't matter.
Mm-hmm.
Pick one that you've done, that you've seen done, that you're comfortable with doing, and you can describe well.
Yeah.
Indications for open versus laparoscopic is probably more important. You're unlikely to be asked about TEPP or TAPP difference. Would you do a TEPP or TAPP, why not a TAPP? It's unlikely, but they may ask you why you would do an open versus a laparoscopic, because the British hernia and the European one and American one and NICE have very specific reasons why you would want to do a laparoscopic versus open.
But the international hernia guidelines back in 2018.
This is where loads of words should appear on your
Lots of words will come up. There are links down below as well, and nice guidelines, and it's always good to drop. They're very simple, very nice to read, and they're quite informative. Not a lot of us, we've surveyed this, not a lot of us read them. Half of us don't read them actually. So it's always good to have a look through these things before these are guidelines that it's worth having. Knowing you're almost always going to get hernia. You
will almost certainly, because even in clinical practice, it's extremely important. It's very easy, no matter what subspecialty you're in. The chances of an exam going by without a hernia in it is going to be very weird and very unusual. There are certain indications. What's the indications to be lap versus open?
So if it's female, to guard against inguinal and femoral at the same time, undetected femoral hernias at the same time.
Yep.
If patient has bilateral inguinal hernias, and if patient requests a laparoscopic approach. This was like a softer indication.
Excellent. Yeah. And recurrence is probably
recurrence as well, different for open, going in for a lap to
ultimately, there are 3 or 4 indications. As Mo mentioned, a female patient who may have a concurrent femoral hernia, or even sometimes obturator hernia, as rare as it is, and that's difficult to get to in open. You want to get to laparoscopically, you can see it. If there's bilaterality, so there's both sides, you don't want 2 groin cuts. It's going to be very unpleasant for the recovery. 3 is if the patient is absolutely adamant they want you to have a laparoscopic hernia repair. It's their choice. If you can't do it, you're going to refer, as we talked about. And 4th is ultimately if somebody's got a recurrence. They've had an open hernia, now they've got a recurrence, maybe a laparoscopic approach is better. But vice versa, if they've had a laparoscopic and then you go to open. Although I appreciate, again, no angry comments in the drop down. Fahad's got enough editing to do as it is. I appreciate there's lots of nuanced differences of opinion, and some people say, no, recurrence, you can still do laparoscopic. Yeah, of course you can. We're talking about for the purpose of the exam. Whatever you did before, you're going to do the opposite. So if you did open before, do lap. If you did lap before, do open. That's the safest answer.
TAPP or
We're going to talk about both. But we're going to start off with TAPP.
Okay.
Just because TA is before TE. Well, there's no good reason. TAPP is going to be the view that we're usually used to. So that is, again, in an adequately consented, anesthetized patient, etc., draped, pepper and draped. The patient is supine, for most people. Whichever side you stand is up to you. You don't need to go into the specific, but you're going to put a 10mm port or a Hassan port, whatever you do, infraumbilical or supraumbilical. Again, say what you would do, and you put 5mm ports either side. I know some people would put 5mm in different heights. You can say that. That's absolutely fine. Essentially, it's a Hassan port and 2 5s on either side. This is a TAPP, so it's a transabdominal. So you're already inside the abdomen, looking in pelvis. If you want the patient slightly feet up and head down, fine, or roll to one side or the other. Then you're going to do your diagnostic laparoscopy, as you'll always say in any surgical procedure that involves laparoscopy. You're going to have a look around. Then the first thing to do is you are going to take some pictures for medical legal evidence and for records. Then you're going to do your dissection. Pull down the peritoneum, whether you use scissors, diathermy, hook, whatever. Does not matter. Don't get bogged down in that detail. Open the peritoneum, medial to lateral, lateral to medial, doesn't matter. You fully open the peritoneum. What's the structure that's not all that important, but can give you a nasty bruising if you hit it when you do your dissection? Inferior epigastric artery, not really consequential in terms of general health, but it gives you a fantastic bruise. Not speaking from personal experience, of course, but it can cause a lot of bruising if you hit it, so you got to be careful when you're taking the peritoneum down. If taking the peritoneum down, you're going onto the hernia. then you've got a chance to assess as direct and indirect. Sometimes it's obvious, sometimes both.
Mhm.
And then you are going to be reducing the hernia sac off the cord, much in the same manner. Sharp, blunt, diathermy, combination of all of the above. Different people have got different opinions. For the purpose of the exams, it honestly does not matter how you say you do it. Just do it. What are the things we need to look out for in a laparoscopic hernia repair? We've got some triangles, and we like putting things in triangles.
Triangle and pain, triangle of doom.
Triangle of pain and triangle of doom.
Go on then.
Okay, so triangle of doom is a really bad one because that is the triangle between the spermatic vessels and the vas. So this is where you have dissected your hernia back. You've got a nice big pocket, and there's the. We should probably have a diagram.
We'll have a diagram.
But you've got to. Yeah, it's got to be. It's probably going to be drawn in crayon and just held up by fire in the background. But like I said, editing out of Barnet, not Bollywood. But anyway, the triangle of doom is going to be between the spermatic.
Shout out to the Council of Barnet. Please sponsor. Please sponsor us.
If you have any money left,
Yeah.
I still live in Barnet. It's a lovely place. Anyway, you've got the structures that you want to be wary of is between the spermatic cord, the spermatic vessels, and the vas, because those structures are.
Yeah, we're talking about arteries.
Yes, exactly. So the iliac vein and iliac artery, the big scary stuff, especially the vein, very easy to puncture and very difficult to control.
Not recommending TAC there.
Exactly. So you've got to be careful in dissection. Then you very rarely need to go into that space anyway. That's the triangle of doom. The triangle of pain is
where the nerves are coming in from, and that's more lateral.
It's going to be a lateral part, so it's going to be away from the vas and the spermatic vessels.
Don't TAC there.
Don't TAC there either because the nerves cross and so that's a triangle of pain, triangle of doom.
It is, however, a good place to put your local anaesthetic through.
Absolutely. So
for better recovery.
Exactly, but they may ask you landmarks, triangle of pain, triangle of doom. We'll have them in somewhere on the drop down, or I don't know, somewhere. Pending Barnet sponsorship, and then you're going to deploy your mesh. Again, what mesh you use doesn't really matter. It just needs to be lightweight. It needs to be big.
Mm-hmm.
Big meshes, increasing evidence. Big meshes are a good thing. Whether you want to trim the corners, cut it, don't cut it, it's up to you. Shape meshes, not shape meshes, up to you. Deploy the mesh, and then roll the peritoneum over it. What you really want to be sure of is what?
It doesn't roll back.
Exactly. The edge of the mesh doesn't roll back because that's the surest way to get a hernia recurrence. So the mesh has got to sit nice and comfortable.
Form a meschoma.
Yeah, and not and not move when you put the peritoneum on top of it. Then you put the peritoneum on top. Tackers. There's lots of different opinions about it. Use what you like. Purely personal perspective, I use mesh that kind of grips by itself. Guess which one that is. And then I just suture the peritoneum. But there is no absolute right or wrong answer. If you want to use kind of absorbable, non-absorbable tackers, fine. You just got to describe what you say. So you put the peritoneum over the top. You tacked it.
Mm-hmm.
That's it. You're done. You let the gas out. Have a final look. You've done your block, or you've done your local anesthetic.
Yes. Gas out. Hemostasis.
That's it.
Some people might say you might reduce the gas when you're putting the mesh in to allow the more pliability in the abdominal wall and let things kind of calm down so there's not of tension.
Yeah, clinically, to be honest, I tend to, because I suture with a kind of barbed suture, I suture the peritoneum. It's a lot easier if the pressure is lower. So you have a kind of normal standard 12 or 15 pressure when you're doing a dissection and deploying the mesh. But when it comes to actually closing the peritoneum on top of it, it's always easier if it's a bit lower, just because the peritoneum comes together very nicely without you tearing and ripping at it. Again, definitely not from experience. And then you do sign out, and patient hopefully goes home the same day or overnight stay, whatever. And then the post-operative care really is very much identical. We talked about TAPP, but now I'm going to talk about TEPP. A TEPP, totally extraperitoneal hernia repair, is slightly different. Laparoscopic, of course, but the positions of the ports are slightly different. Most people, again, there's variation in practice, but most people would have an infraumbilical port, and they'll have two further smaller and shorter ports infraumbilically as well, taking care of the bladder. The difference between TEPP and TAPP, essentially, apart from the port positions, is in TEPP, you're not actually entering the abdomen. You're between the fascia and the peritoneum. Therefore, the initial dissection is very, very important that you don't breach that peritoneum and end up in the abdomen, because then you're doing a TAPP. So it's a little bit more kind of nuanced and careful dissection is required in the initial part, certainly. Once you're in, your ports are in, you're also working in a slightly unnatural kind of position, especially if you have the ports in one line. Be careful of the bladder, as we mentioned. What's important to remember in TEPP is that the space we're in is actually not one that's very natural, I think, for most of us. We're used to seeing the abdomen from inside the peritoneum and seeing the whole thing. Seeing in that space between two can be quite disorienting. I must admit, when I was kind of training to do the procedure, it did take me some time to try and get my head around. But ultimately, you're in a space that's not very familiar. So you got to take extra care that you know what is what, and it can be very difficult. Ultimately, some people do make that space using a space maker, a balloon. Some people use just the camera to dissect it. Whatever you use, you want to make a pocket, a working space, as it were. Once you've got that working space, you then have to have a good idea what the structures are, because a lot of the big structures, like the inferior epigastric, for example, is right on top of these, right in front of you very quickly. Once you have identified the structures and made your space and made sure there's hemostasis and you haven't caused terrestrial bleeding, then you're going to do your dissection. What are you going to do? The same principle, really.
So it's exactly like you say, you're creating a room in a space where there's a potential space and you're actually making an actual space. So you're pulling pushing the peritoneum down. And as you do, bits of the peritoneum that produce fat that are involved into the hernia are going to make their way over. And you want to pull them away from the posterior wall of your inguinal canal. If you look at it, you're outside the inguinal canal and you're peeling the wallpaper outside of the inguinal canal, essentially. Obviously, not going to say that in the exam. You're going to continue to dissect, push the peritoneum down, taking care to dissecting the lumps of fat out of the cord and of the posterior wall to identify the defect. It's an indirect hernia. That's when you need to pull contents off the spermatic cord and reduce the hernia from inside. It's a direct hernia. You're pretty much reducing the contents automatically, and just pulling the peritoneum out will do that for you.
Exactly. You made your space. It's the same principles. You made your space. You have identified where the defect or defects are, and whatever's attached to the structure that shouldn't be, round ligament, spermatic cord, whatever, you're going to separate the two. Again, combination of sharp, blunt, diathermy, whatever you want, ensuring hemostasis. You've reduced the hernia, and now you're going to
deploy your mesh.
You're going to deploy your mesh, whatever mesh you use. Again, the same. Some people don't use any kind of fixation whatsoever. There's various things, glues, tackers, none, sutures, whatever you want. You deploy a mesh and you slowly let the gas out after you have ensured hemostasis. Ports are out, gas is off, and you're going to watch everything deflate.
Again, quickly recap all of this. The buzzwords here for an open repair: it's tension-free, ensuring recurrences don't happen, naming the recurrence places that happen, ensuring that hemostasis. For a laparoscopic approach, buzzwords here are ensuring that you're talking about the indications, citing the guidelines appropriately, and citing what you would like it to look like when you're operating, and also citing where the pitfalls, where the complications, where the important structures that you need to preserve.
Absolutely, and that's where the triangles that we already mentioned comes into play. Just know what they are. But that's it. Ultimately, that's all you really need to do. But it needs to be practiced in your head a few times. And even more importantly, it needs to be vocalized, because often we know what we know in our heads, but when somebody actually asks us on the spot, especially under exam tension and stress, it can become very difficult and very awkward to vocalize what you want to say, even though you know the topic very well. There is no substitute and no replacement for getting into groups or small groups and just vocalizing over and over and over again.
Getting the reps in.
That's it.
Get the reps in.
I think that's a good place to wrap up now. And we'll see you next time.
Thanks for coming in.
I've taken that out.
Sorry.
I've absolutely taken that out.
Sorry.